MS Plus acknowledges the traditional custodians of the land this podcast is recorded on, the Wurundjeri people of the Kulin Nation. We pay our respects to their elders past and present.
Hi, and welcome to the MS Plus podcast series. My name is Jess, and today I'm lucky to be speaking with Fiona Easton. Fiona is the MS Plus Continence Nurse, and she's been working with MS Plus for over 16 years. So Fiona's main role involves conducting the continence clinics based here at the MS Blackburn site, as well as the MS Watsonia and Williamstown supported living sites in Melbourne. Fiona's background is that of general nursing, and she's currently a registered continence advisor. She also has a 4-year psychology degree and has experience in palliative care and crisis counselling. So, given Fiona's background, she's the perfect person to be speaking to today about the bladder and how menopause has an impact during this time for people who both have MS and for people who don't have MS but are going through perimenopause and menopause. So can you tell me a little bit about what menopause actually is?
Look, menopause is a condition which is not really talked about much, but it's a couple of years after the woman has ceased menstruation and she doesn't have any periods anymore. There's a lack of estrogen, there's a lack of testosterone, and basically vaginal dryness happens. The bladder is impeded in many ways, which I'll talk about later. But to be honest, Jess, it's the perimenopause area it's a really awful time for a woman because she doesn't really know what's happening because all of a sudden she might have an exuberant amount of serotonin, and within, say, 6 months, she may have depressive symptoms out of nowhere. So the perimenopause time, which is probably about 3 years lead up to the cessation of the periods, is a really difficult time because usually women don't know what's happening to them. And it does happen at various stages. Some women go into perimenopause at 38. For me, it was 48, and I thought, gee, what's happening with my feet? They're very hot. And then started to have some mood changes. Never had mood changes in my life. I personally went on a testosterone type of tablet for 7 years. It was fantastic. So that really got me through the hump. That's me. That's not everyone else. But bladder changes do happen during perimenopause and menopause.
Yeah, right. And, even in my research the other day, just reading that perimenopause can last years, up to 10 years, which is a long time when you think about how long in a woman's life she could be affected by these symptoms. So when we're talking about the bladder and even to do with perimenopause and menopause, what are some of the changes that can occur?
Look, in a younger person and an adult woman and a woman going through menopause, the bladder's loaded with estrogen receptors. So in perimenopause and leading up to menopause, these receptors are just dumbed down and they fall away. So with that, estrogen gives you elasticity, it gives a thickness to the bladder and vitality, basically. So when that estrogen is fallen away because of, say, normal hormonal changes, things start to happen. Things like vaginal dryness. If you've got a female partner, a male partner, it is hard for any sort of sexual intimacy. There are such things as, and I've got it in my hand here, and this isn't mine, but it's Vagifem. And so this is just 10 micrograms of estrogen, which is localized into the vagina and around that area. Also, too, the urethra thins, it's sore. The woman can have a lot more UTIs because it's vulnerable. Things like basic stuff like wiping from the front to the back. I know most people do that, but even one tiny zenith of fecal content that can get into that urethral tract, bang, you've easily got a UTI. And there are wonderful medications such as D-mannose. People may not know about this, but this is really good for prevention of UTIs, especially in a woman's perimenopause time of her life. The D-mannose is a natural tablet that adheres to any fecal content, which sounds awful, but it's true. The fecal content can, as minutely as it is, can hop into the urethral canal and cause some awful UTIs. And we've since known that UTIs can cause like a colony in the bladder, and they can embed, and even one dose of antibiotics will not get rid of it. So this is new research that I've been looking at. Often I have clients who come in who are perimenopausal, who have look, they have MS, so that's another added bonus for them. And they've got these UTIs that they've had over and over for 6 months. So Dr. Helen O'Connell, a great urologist, has talked about long-term antibiotic therapy. We're talking like 2 years, 1 year, which seems Frankensteinian, but it does work because the germs embed themselves into the bladder wall, and only through massive amounts of and long-term amounts of antibiotics will actually cure that person.
And so, just taking it back a step, we're talking about bladder function and how that changes with menopause. But what is typical or normal bladder function? What does that generally look like for people?
Look, normal bladder function is you get the sensation to go to the toilet, you can produce 4 to 600 ml at will, your bladder contracts nicely, your sphincter relaxes. So the door is open, you pass the urine, really that's it. You don't have any sensation to go and then you go and there's only 2 drops. Normal bladder function is you get the sensation, you have the bladder contract when you're over the toilet, and usually it's 4 to 600 ml. With menopause, because of the thinning of the bladder wall, and you have overactive bladder symptoms because of lack of estrogen and other things. Sometimes women say to me, gee, I only pass 100 mil. And also, too, I'm forgetting about the big gun in this, which is the pelvic floor. I have actually asked my daughter, do you have any stress incontinence? I'm jumping here, but she's had a couple of children. She's a nurse as well. She said yes. So I said, are you keeping up with your pelvic floor exercises? She said, no. So the pelvic floor is a big gun. It's the world heavyweight boxer in the ring that you really need to engage. Some women don't have that chance because they have an episiotomy, and it unfortunately cuts through not only the perineum but the sphincters of sometimes bowel and bladder. If you've had a really not dodgy or bodgy, but sometimes these things can't be helped. So you've got lifelong problems with bowel and bladder, which is awful. There are medications, though, for overactive bladder for both menopausal women, but they often have anticholinergic effects and can dry out the mouth. But if you can keep up your pelvic floor exercises with a good physio who deals with continence issues.
And so, for women with MS, because obviously we know that MS comes with its own bladder issues and implications, if a woman with MS is then going through perimenopause or menopause, how hard is it to work out where those bladder changes are coming from? How does it look for someone with MS who's going through menopause?
Good question. And a lot of my clients fit into that 50 to 60-year age range, and often their GPs will say, "No, it's just menopausal," and 9 times out of 10 it is the MS. So the MS is influencing the menopause. And I always say, "Look, I would try an anticholinergic for the overactive bladder, plus let's look at some estrogen cream and also the pelvic floor exercises." But as well as that, Jess, some women who are 50 or 60 don't have the mobility and actually can't feel that they're tightening their pelvic floor. So I just say to them, if you can get to a pelvic floor exercise expert, they can measure. It's a bit invasive, but they can measure to see, hey, is your pelvic floor tightening around the instrument? It's an internal examination, but at least they've got a baseline. So really difficult. You've got the double whammy of perimenopause and MS.
Right, okay. And so you were talking before about, UTIs and that becoming a frequent issue, but are there even changes like to the skin of the vulva and the vagina? Like, can you tell me more about the changes that can happen there?
Good question. The labia minora and majora will thin out. So instead of just being young and plump, they become like paper thin, easily, I say open to infection, but easily bruised. Salt water is good for this area in that time of life. Salt water just to keep the area fresh. Lubricants, of course, are good, but if you're having that dryness, it's painful during intimate times, the estradiol is a good thing. And also, yeah, I'm thinking the bathing is good, the normal saline bathing. Also, to exercise, if you can do that, will bring more blood flow down to the perineal area. A lot of women have low moods, but there is a drug called Livial, which a lot of women don't know about. If you haven't got heart disease or heart issues, it's fantastic. It can cause you to want to box every second person you walk past, but it certainly gets rid of the, "Oh, why am I here?" and "What's happening with my life?" and things just seem to be going down a tube. So the Livial is fantastic if you've got a good GP and can get you over that hump of the 5, not so much 10 years, but a 5-year dose of Livial's fantastic. So a lot of women will go down the progesterone or estrogen route. Sometimes that will, well, often it will give you a moody perspective. So there's good gynaes and there's good obs and there's good, some male GPs are absolutely crapola. They just give a script for, it's like they're quite bored with the whole situation. Not every GP's like that, but I'd be really shopping around.
Yeah, absolutely. And so I guess when we're talking about these changes, what are some things that women should really be aware of that aren't so helpful to do? Because I know when I've spoken to women in the past who've maybe had some bladder issues, they'll be telling me, "Oh, I don't drink as much water when I go out to sort of reduce the chance of having an accident." So what are some things that aren't so helpful and that people shouldn't be doing?
Good question. And a lot of my MS clients dumb down their water intake. I can certainly understand that because some MS clients have not only urinary incontinence but fecal incontinence. So you just wouldn't want to be caught out. I understand the concept, I get that. But for someone, say, without MS and is in perimenopause, drink as much water as you can. And also the pelvic floor, it's still there. Like it holds all of your organs. It's a floor that often becomes lax during menopause because of the thin tissue and the supportive structures become a little bit thin and weak, but like a boxer, try and build that pelvic floor. You're right about the water. Keep up the water intake because that will flush out any toxins as well. And also too, there's the key in the door syndrome that like your 25-year-old might have, your 35-year-old might have after a couple of children, and definitely your 55-year-old woman will have. So pelvic floor, keep up your fluids and keep that normal saline, those washes in the perineal area, keep it clean so that there's less chance of UTIs.
Right, okay. And so for the majority of women that will go through perimenopause and menopause and have these changes, does that mean when your bladder is affected by menopause, it will stay like that? Can it be improved? Or are these just things that women have to learn to live with?
After menopause, the pelvic floor you still have the capacity to reduce the leakage. Sometimes, women don't get full 100% cessation of leakage, but things can get a lot better. As for the labia minora and majora and the dryness, that stays. That stays. You've just got to work around that. So menopause is menopause. There's testosterone derived tablets, and a good gynae would help you to prescribe the right creams for that perennial area.
Yeah, right. So thinking about menopause, perimenopause, and the changes that it can make to your body and the areas that it's affecting, it sounds like a really sensitive time for people. So how can women feel safe to sort of start that conversation if they don't know how to raise it?
The best place to start would be the Jean Hales Clinic because they've heard it all before and there's really accommodating women there that have heard it and it's a safe space. So find a GP who's female who has an interest in perimenopause and menopause. And it is a big deal. Like for me, it was a bigger deal than having children. It was a shock. Nobody had prepared me for it. And I thought, what's going, and it wasn't just the bladder changes, and it was the whole persona of who I was, like, up for grabs. So I had a good GP. I said, "I don't know what's happening here, but I think I do, but it can't be this." So GP conversations, right medication. Often the GP will offer you SSRIs, so you antidepressants. I said no, so that's where I was given the testosterone-derived tablets, which suited me for 7 years. But it is that conversation with your GP, and women's groups will talk together and say, "That GP's good." So I suppose it's just the sharing of knowledge, how we've always done in the village, but it does need to be talked about a lot more, Jess, yes.
Yeah, it's interesting. It seems that menopause is almost this big secret until you're approaching it or going through it. And there's not a lot of information until you're actually there about what's ahead and what's going to happen. So I think you're right. It definitely needs to be a bit more open discussion for women. So, what would be your top strategies or tips for women who are having these bladder changes to help manage their symptoms a bit better?
The first strategy would be go to a reputable GP. Get some advice from a reputable GP who deals with women's issues. Then hydrate yourself, normal saline baths. And the gold standard is your pelvic floor. Even if you've got MS, go to a pelvic floor physio who can diagnose and just assess where you're at with your pelvic floor strength, because that will keep you dry, and it will stop that, or at least dumb down a hell of a lot, dumb down those urinary continence episodes.
Right. Okay. And so during this time, when hormones and things like that are having an impact on the bladder, are there external factors that could be an irritant to the bladder? So whether that's alcohol or caffeine?
The caffeine will definitely irritate the bladder. Smoking is as bad as pelvic floor exercises are good. So smoking, people could do what they want, but I don't make the rules up about anatomy, but smoking is just such an irritant to the bladder and to the whole anatomy of the person. And I've had clients who've had MS who continue to smoke, and just that they just have 100% more issues with bowel, bladder than your regular person who has that MS for the same amount of time.
Yeah, no, definitely. I think it's really good information and a really good reminder that if you are a smoker, to maybe just see what you can do, get some support to try and quit smoking, because it has just such a profound impact on so many areas of your health. So I think that's a really good point as well. And so it sort of touched on urinary tract infections and things like that. So what are some of the challenges that women going through menopause face regarding urinary tract infections and UTIs, and how can they manage those?
Look, the urinary tract infections for women with menopause. Please don't forget your probiotics, and good probiotics, not just ones that are on the shelf at Chemist Warehouse. The probiotic is like the driver of a bus. It really gives you bowel health, and your system is healthy as well. So if your bowel is healthy, you're healthy. So probiotics are really good inclusion for someone who's going through, or when they know they're going through perimenopause. Urinary tract infections, some women who have hyperemesis, you can't do anything about it. They have vomiting during the first, sometimes 5 months of pregnancy. That's the same with UTIs. Some women, unfortunately, are just set up that way. If they get one UTI, it's one after the other. They'll trial Macrodantin, Keflex, all the big guns, IV, maybe gentamicin, and they always seem to have a UTI. I've had one woman come to the Blackburn office saying that her urologist has said, "Look, you need to remove your bladder." It's like, do they ever say that about men? "Oh, you're not weeing properly." No, they don't say that. But no, the bladder, they'll remove. So I'm working with her to try and get a long-term antibiotic therapy happening. And she also self-catheterizes too. But her body's set up, also depressed and stressed and perimenopausal. Yeah. Some women are very challenging, and I really feel for them. So we do our best to try and, I don't know, cut out the variables and make sure that she's got a straight path to try and manage as best she can.
Yeah, right. It sounds like, perimenopause, menopause clearly brings a really complex mix of challenges, but it sounds like with a lot of the right information and support, as you said, having a good GP, having a women's health specialist, women can navigate these changes more effectively. So the information and tips that you shared today, Fiona, have been really helpful. So thank you so much for sharing that really valuable advice. And hopefully this conversation will help women feel a bit more empowered, a bit more prepared, or even just understanding what's happening as they're going through and navigating these perimenopause and menopause changes in their lives. So thank you.
Thanks, Jess. Listen, the last thing is perimenopause is like having a shroud over your head and you're having some hot flushes, and you don't know where you're going, and you're going into this maze without a map. So if you find a good GP, and also too, blood tests and saliva tests don't pick up that you're in menopause till really it's too late. And the GP will say to you, it sounds like perimenopause, which is the tough gig. When you reach menopause, you get back to yourself. You're just back to yourself. But that traveling to menopause is the hard bit.
Yeah, it definitely sounds like a time where women really need that support and need all the information possible to navigate through it all. So thank you so much again, Fiona.
For more information on anything we have covered today, please get in touch with MS Plus Connect on free call 1800 042 138 or email connect@msplus.org.au.